So I'm going to discuss three things. One, the changes in medicine and the fact that these changes are happening whether we like it or not, that these changes necessitate our changing our residency programs, and then a strategy for affecting change. I was an intern in 1963, and at that time, the Brigham's average length of stay was 15 days. It's now 3 days. During my internship, we admitted the first patient to get chemotherapy at the Brigham. Now that fills a third of our beds. We used to work every other night, every other weekend, 120 hours a week. Now the work week is about 80 hours or a little less, and the on-call shifts, which over the weekend used to be 60 hours, the longest is now 24. And then the other thing that's really different is there was no ambulatory block time when I trained. And I think that's a very important training experience. And so all these changes mean we have to change our program. We work in different institutions, and no one size fits all. So when we make our changes, we have to incorporate in our changes the individual strengths of our programs and their weaknesses. What I would do, what I found was that the residents, rather than the faculty, were the source of my most successful innovations. And I would ask every incoming resident and get them one-on-one and say, what did your school do better than we're doing at the Brigham? And then I'd steal those ideas. And I would meet with the residents weekly and tell them I need to know what was broken. And I would tell them that I need their help in making the program better, and that it's much better to light a candle rather than curse the darkness. Once they had identified a problem, I'd get a small group of them together and say, okay, come up with a solution. And then they would have a suggestion, and I would discuss that at several of the weekly meetings of the residents. And this was very important because when the new program that we carefully discussed and vetted bombed, it wasn't my program, it was our program. And I think that was important. And interesting, despite all that careful vetting, only about 60% of the changes I introduced actually worked. Now, Ted Williams only hit 4 or 5 in his best year, so I thought mine was a satisfactory batting average, but you won't bat 100%, and you often are really surprised you've worked real hard on the change, and then you try, it doesn't work out. If I were a program director today, I'd ask my residents help with 3 issues. First is work hours. I think the present work hours guidelines are far less than optimal. 15 years ago, when my youngest son was an intern, I had a great idea, based on his experience, of how to redo the program, and it was going to be fewer hours, more sleep, better continuity. It was fabulous, and we were prepared to study it. The Residency Review Committee wouldn't let us do that. So you have to lean on them. They are loosening up a little bit, but it's really important to get them to buy into change. They sometimes don't seem to have heard of Francis Bacon, who said that the scientific method is you have a hypothesis and then you test it. They seem to think that you look up and you find the answers. I don't think so. Okay, the second thing that I'm really concerned about is medical residents, and there are now 3 papers in the literature, now spend about 1.5 hours a day face-to-face with patients, and 5.5 hours a day face-to-face with Epic. And that should be reversed. And then the last thing I really think is our trainees spend too much time caring for highly specialized patients, especially on the inpatient service. People in the bone marrow unit and places like that, that's much more appropriate for people doing fellowship programs. And I think we need to get them to spend more time in ambulatory care. And we actually looked at growth of inpatient skills versus ambulatory skills. Inpatient skills is this S-shaped curve. The second corner is about 21 inpatient months for a medical resident. Ambulatory skills go up linearly for about 6 years. So we need to have a better balance between those two things. There is a problem, and that is house staff are a revenue generator on the inpatient service and a cost center in the ambulatory setting. So making that change is going to be challenging. I've had my day. I'll be watching you. I wish you all the best.